Today, we're putting on our detective hats. We're about to investigate one of the most difficult puzzles in all of medicine, the sudden onset of psychosis. It's a journey that's really going to challenge our assumptions and show us just how connected our minds and bodies truly are. So let's get started. So picture this, a young person, totally healthy one day, and then suddenly their world just starts to break apart. Their thoughts get jumbled, they're seeing or hearing things that no one else does, and their whole personality seems to shift. That's where our case begins. And right away, the clinician is facing a huge question. What on earth is going on?
For the longest time, the go-to answer, the first chapter in the textbook would be a primary psychiatric disorder. We'd immediately think of something like schizophrenia. And that makes sense, right? It's the most common and logical place to start.
But here's the twist. What if all those psychiatric symptoms, what if they're just the tip of the iceberg? What if the real root cause isn't in the mind at all, but it's the body's own defense system launching a full-on assault against the brain? This is where the real detective work kicks in.
Okay, to really get this, let's open up a case file. We've got a 17-year-old. She's suddenly become totally convinced that everybody, her friends, her family, can read her mind. And not only that, but they're mocking her for it. She's not questioning it. She is certain it's real. So naturally, she starts pulling away from everyone. On the surface, this looks like a textbook case of psychosis. But is it?
All right, let's zoom in on our prime suspect. This is a condition that is an absolute master of disguise. Autoimmune encephalitis. And this is where that line between neurology and psychiatry gets incredibly blurry.
So what exactly is autoimmune encephalitis, or AE? Well, think of it like this. It's a case of friendly fire. The body's immune system, which is supposed to fight off viruses and bacteria, gets confused. It creates these antibodies that, by mistake, start attacking really important parts of our own brain cells. This just throws all the brain's normal signaling into chaos, and the result is a whole storm of symptoms that can look exactly like psychosis.
So how can doctors spot this imposter? Well, they've got a checklist of red flags. Think of these like the clues a culprit leaves behind at the scene. Did the psychosis come on super fast, like out of nowhere? Are there any weird movements, like involuntary twitches? Is the patient having seizures? Or are they having a really bad reaction to the standard antipsychotic meds? Any one of these should make a clinician hit the pause button and think, wait a minute, could this be autoimmune?
Now, check out the typical timeline for the most common type, which is called anti-NMDR encephalitis. It often kicks off with what feels like the flu, maybe a headache, little anxiety, but then it explodes into full-blown psychosis with delusions and agitation. And it doesn't stop there. It keeps going, leading to movement problems, a person becoming less responsive, and some really serious neurological issues. That progression, that escalation, is a huge piece of evidence that something more is going on here. And to make the case even tougher, AE isn't just one thing. There are different types. On one hand, you've got limbic encephalitis. It usually hits older patients, causes big-time memory problems, and you can often see it clearly on an MRI. But on the other hand, you have anti-NMDAR encephalitis, which is more common in young women, has all these bizarre behavioral symptoms, and get this, the MRI scan can look perfectly normal. That makes the detective work so much harder. But hey, our investigation is far from over. These autoimmune conditions aren't the only bad guys on our list. Next up, we've got to look into the accomplices, other things that can trigger psychosis. When you hear substance-induced psychosis, your mind probably jumps straight to street drugs, right? But the list of things that can cause it is way broader and honestly, kind of surprising. We're talking about common, prescribed medications, things like certain antibiotics, heart medicines, drugs for seizures, and even steroid treatments. So going through a patient's entire medication list with a fine-tooth comb is absolutely critical. So how does a doctor tell the difference? Well, a huge clue is the clock. In a lot of cases of substance-induced psychosis, once you stop the drug and it clears out of the body, the symptoms get a lot better or even go away completely. But with primary psychosis, the symptoms stick around. They don't just disappear on their own and usually need long-term treatment. Okay, we've got our suspects lined up. Now, let's open up the clinician's toolkit and see the actual techniques they use to solve this incredibly complex puzzle. Cracking this kind of case takes a really systematic approach. First up, the doctor takes a deep dive into the patient's history. Any recent infections? Any family history of autoimmune disease? Then they do a super detailed physical and neurological exam looking for all those little clues, like weird reflexes. After that comes the really important lab work where they test not just the blood, but also the fluid around the brain for those rogue antibodies. And finally, they use advanced brain imaging to see what's happening inside. And speaking of imaging, this is a huge deal. Remember how we said a standard MRI can look totally normal? Well, look at this. On the left is the MRI. It doesn't show much, but on the right, that's an FDG PET scan. It measures the brain's energy use, and wow, you can see these bright spots where the brain is overactive and inflamed. This, right here, can be the smoking gun that changes everything. So why go through all this? Why all this intensive detective work? Because solving the case doesn't just give you a name for the problem, it points you down a completely different and potentially life-saving treatment path. This slide just lays it all out. It's a critical fork in the road. Path number 1 for primary psychosis is to use antipsychotic meds to manage the symptoms. But path number 2 for an autoimmune cause is to use powerful immunotherapies to stop the body's attack. It's the difference between just managing the smoke and actually putting out the fire. And look, this isn't some far-out fringe idea. As the researchers who we drew from for this explainer put it, just being aware of this possibility is opening up a whole new field in psychiatry. It's a total game changer for a small but incredibly important group of patients who could otherwise be misdiagnosed for years. At the end of the day, that's the moral of our story. Getting the diagnosis right can mean the difference between a lifetime of just trying to manage symptoms and actually getting a shot at recovery by treating the real disease. It is, and I'm not exaggerating, completely life-changing. So as we close the book on this case, what's the big takeaway here? What does all this mean for the future of how we diagnose these conditions? Here's the most important thing to remember. Psychosis is a symptom. It's like a fever or chest pain. It tells us something is seriously wrong, but it isn't always the final diagnosis itself. It's the beginning of the investigation, not the end. And that means that for everyone involved, the doctors, the family, the patients themselves, the most important question we can ask is the same one that drives every good detective. What else could this be? It's a question that keeps us curious and pushes us to not just accept the first, most obvious answer. And that leaves us with one last really big thought. This whole deep dive forces us to ask a much larger question. How many conditions that we've always labeled as purely mental are actually rooted in the physical systems of our bodies? Honestly, that's a frontier that medicine is just now beginning to explore.